I'm Jutta Bergler-Klein, and we will summarize the facts about aortic stenosis. In summary, aortic stenosis is very common and is usually caused by either congenital abnormal valve, especially bicuspid valve, or progressive degenerative calcification of the aortic valve, especially in old or elderly people. It leads to increased afterload and left ventricular hypertrophy, and finally left ventricular dysfunction. Importantly, the quantification of aortic stenosis is based on the gradients in continuous wave Doppler and the calculation of the aortic valve area by the continuity equation. The shape of the spectrum of the Doppler jet can point towards severe aortic stenosis, especially if we have a late peak in systole. And it is extremely important to remember that we have to look for the peak velocity with echo. This can sometimes be challenging, and it's important to use several windows to really get the peak maximum velocity that we need to calculate the gradients and the aortic valve area. Finally, watch out for the mitral regurgitation signal, especially if you have a medial jet, which might be mistaken for an aortic stenosis systolic jet. Severe aortic stenosis is defined as a mean gradient above 40 and an aortic valve area below 1. If we have patients with atrial fibrillation, we have to average the beats, also in other arrhythmias. It's important to remember that we can have underestimation of aortic stenosis if the left ventricular function is reduced, the so-called low flow, low gradient aortic stenosis. On the other hand, we can have overestimation of aortic stenosis in high flow states, especially if we have moderate to severe aortic regurgitation. Discrepancies of cath lab and echo measurements can sometimes be explained by the phenomenon of pressure recovery. Clinically, this is important to remember in patients with a small aortic root or in moderate aortic stenosis, and is frequently encountered in small women. So in summary, when is surgery needed? Surgery or intervention needs to be performed if the patient becomes symptomatic or if the left ventricular function is reduced. Other factors of influence are the need for other heart surgery, the degree of calcification, rapid progression of velocity or gradients, or the detection of subclinical left ventricular dysfunction with new echo or imaging techniques such as speckle tracking, strain imaging, and biomarkers from venous blood such as BNP. Other causes of aortic stenosis include the sub- or supravalvular stenosis caused by congenital defects, frequently with membranes or fibromuscular ridges. These forms of stenosis are uncommon in adults and are usually found in children or young adults. They have the same physiology as aortic stenosis in calcified or bicuspid aortic stenosis. And we should think of these entities or suspect this if the aortic valve is normal, but the measured gradients are high, or if we see turbulences or color aliasing. We should check for membranes or other outflow tract obstructions.